A lot of times people do not know when they have pelvic inflammatory disease, especially with things like chlamydia history, a proper physical evaluation, and come to a reasonable diagnosis within the framework of time given to them to evaluate your illness. The average patient would have been a patient who was a workers' comp patient for, let's say, maybe 6 months to probably 2 to 3 years, and going to a doctor's practice for therapy, for actually different modalities of treatment. And this physician probably would have seen that patient either from the time they were injured to the time now. And let's say that period of time spanned for a year. Now they would have seen that patient going through the limping into the office, inability to walk, to the time we're now able to walk with the aid of a stick. Sometimes not all the time, but sometimes most of the time. But they've been able to see the progression of that patient. I've got a simple patient in my practice who had a fracture of a lower bone in the spine from a push or a shove that he allegedly have from an employee, and he fell. The issue is that the doctor who's doing the IME does not know you from that time, has not seen how you progress. So you go to the independent medical evaluation. Your role is to tell that physician, doctor, you've got 30 minutes to spend with me. And over that period of time, I want you to do 2 to 3 things for me. I want you to listen to my history. And when you finish with my history, then you can do your physical evaluation. But I want you to record the sequence of events that transpired prior to me coming to you here. This is what happened to me a year ago. I tripped and fell, and I injured my lower back and my hip. And from that time, I was unable to work. I was unable to walk. But let me tell you what I go through on a daily basis. And it's so important for us to understand when we go for an IME, what is it we need to be able to tell that doctor? A couple of golden rules that you should take with you. One, you should not be afraid. The doctor is not there to scare you. He is going to take a history from you. But he's being paid to look after you. And you are the person who's in charge at that time. But be polite in being in charge. But also dictate to the doctor, I want you to listen to my story as I tell you how I've progressed, what I am now at this stage. In our next discussion, I will tell you how to itemize those things, because a lot of time we as patients, we go before the court, or we go before another physician, or we go for an examination on the oath, and we think that we actually going to be prosecuted for saying the truth. At all times you say the truth, but record it in such a fashion that you will remember. And in our next discussion, I will tell you how to proceed with an examination by another physician, by an insurance carrier, as regards what your symptoms are. And sometimes it's for us to know how to do it that makes the more important for us to be able to tell the truth at all times. But the truth itself has to be coming from us. And it has to be coming, if you do not volunteer it, it's never going to come from you. In our next discussion, we'll go through what are some of the activities of daily living that physicians, healthcare personnel are interested in knowing, even when they're on the other side of your case. Let us consider you as that patient who is going for that independent medical evaluation. And all that means, it's an independent medical evaluation. It's done by an independent doctor who is not your primary care physician, your family physician. It's an independent doctor chosen by an insurance carrier. And the rest of it, medical evaluation, is the same that you've gone through maybe 10, 15 times in your life as you see your doctor. So what is the aim of this independent medical evaluation? Let's say, for instance, you are that person in my practice who's got an injury to the lower back, the hip, and the knee. And your complaints are, doctor, after I tripped and fell at work, I sustained injury to the lower back, the hip, and the pelvis. Or I was involved in a motor vehicle accident, and I sustained injury to my lower back, hip, and knee. How do I know I sustained injury? I was pain-free prior to the incident, and now I have pains. So these pains are as a result of the incident or the accident. So the independent medical evaluation is for you to say that this is as a result of the accident or the incident, and this is what the sequelae of that injury is. And who best to describe what's going on with you than you yourself? But it's also important that you actually be able to remember it graphically. And sometimes you need particular cues to remember things. Because remember, medicine for you is not your primary profession. It is something you happen to be involved with because of your accident. And now you're faced to go before another doctor whose intent is probably to negate your injuries as much as you possibly can and to make light of the fact that your complaints and treatments are probably not really necessary and was just done in the interest of you or your physician or the facility you're going to. Albeit a lot of times physicians whose only income depends on this kind of practice tend to overutilize it. And most of us who've got fairly decent sized practices that do not depend on workers' comp or no fault tend to go on the lighter side and trying to negate in terms of as many treatments as possible and trying to get your patient back into the workforce, as we all should be at this stage, at least in the crisis we're facing with our economy, but also for your own professional standards, and not to be milking the treatment of a patient based on the simple fact it's going to utilize or give you more monies. What I've done in the past and seen in the past is that facilities that are run solely for the purposes by non-physicians or those intent on making monies out of no-fault or workers' comp tend to be in a position where they overtreat or overutilize expensive care that probably could be done with much less expensive. And we have to be fair that a lot of times the activities of a few affect the majority of us who try to refrain from that sort of activity and basically be on the mainstream of providing treatment as necessary or being on the side of the patient. I will give you another week for you to get better, because lifting 50, 60 pounds of carpet, trying to move from one place to the next is not going to really help your back. You may want to go back to work, but I know you're going to be back in a couple of weeks with exacerbation of your symptoms. So sometimes the physician can actually use his own judgment and say what is necessary. You are a person who was injured at work because you were punched in the face by an inmate at an institution in which you are a worker, and basically you got to go back to the same environment. Your major disability is the fear you carry about the punch that was launched at you and the neck pain you're having. So sometimes you've got to equate what is the environment you're sending that patient into, what is the impact of the environment has on the person's physical condition. If it's fear from the impact of a head injury as a result of a punch from an inmate, then obviously you're not so happy to go back into that environment unless you think you can cope with it. The same applies to that person who's injured their back and has to carry 30 to 40 pounds here and there and launching the carpets up and down staircases. Is not going to be happy doing that. But a person who's got light duty, sedentary activities, injured to the lower back, and basically faced with in front of a computer probably can tolerate the activity much more. But the issue with this is that when a patient goes for an IME is to remember what happens to you from the time you go to bed at night. Let's say, for instance, that same patient of mine who's got an injury to the back, to the pelvis, to the hip, and to the knee after that trip and fall at work. You explain either to the judge or to the IME physician that basically, doctor, by the time I go to bed, there's no position that I can assume that does not elicit pain in either my lower back, my hip, or my knees. I cannot have normal activities that I was capable of with my spouse because of the simple fact of the amount of pain I was having. That has resulted in a little bit of a strained relationship with my spouse. Now, when I go to bed at nights, I twist and I turn before I can actually find a pleasant position where I manage to get an hour's sleep. I'm rudely awakened in the middle of the night with the aching pains that I get in a particular area, the back, the hip, the knee, etc. I wake up at night to go to, when I get up from the bed to go to the bed, I cannot even put my foot onto the ground because I'm unable to establish if my weight, the weight of my body, is going to be able to be sustained by my lower limbs because of the pains I'm having in the hip and the knees. I try to bend down to pull down my pants to go to the toilet. I'm unable to do that independently because of the aches that I'm experiencing. When I'm finished doing what I have to do, when I try to pull it back up again, I go through the same periods of pain. Then I go through another hour or so before I attempt to fall asleep, maybe with the help of an analgesic. Here again, I go through many, many nights, and all my nights have been like that, where my sleeping pattern is being disturbed episodically or protractedly, and now I'm not able. When I get up in the morning, I feel very tired. I have to decide to get out of bed. When I get out of bed, I go through the same thing again. I'm unable to establish the validity of my weight on my legs. I'm able to go to the bathroom, take care of my private needs. Sometimes I need the help of my spouse or my children in order to zip up my pants if that injury happens to be in the hands itself. When I go down my staircase, I have to tread gingerly to get down my staircase, forwarding with the good leg and then falling with the bad leg. If both are injured, then I walk down the staircase, or sometimes I even drag myself down the staircase. In terms of getting out of my house, even to come to the physician's office, it takes me almost 3 times as long to get out of my house. I have to be careful when I get off the pave and I step into whether a taxi, which is taking me to the office, or I step into a car. I'm not able to accommodate myself in the car because of the simple fact I've got to fold myself in 2 or 3 positions, with my knee being bended, my hips being bended, my back being straightened. And those are the positions that actually exacerbate my pains. So the activity of daily living, while not difficult to establish, has to be in your mind from what you go to bed with, what you wake up in the nights with, how it affects you from the time you go to bed, the relationship with that person who's been significant in your life. How does it affect sexual activity? How does it affect when I get up at nights to go to do my number 1, my number 2? How is that affected? What happens to me in the morning? Can I use my hands as freely as I did before to zip up my pants, to go to the bathroom, put on my shirt? I need help to do this. Am I able to eat breakfast independently? No, sometimes with a stiffness in the neck or the inability to use your arms, you're unable to do that. But unless you're able to describe these events in as lucid and as clear a fashion to the person who's examining you, then your case is half lost, because you are the one who is responsible for telling that person. You're the one who's telling the story of Mrs. Jane, who was injured at work and is now having these serious limitations of activity because of a simple fact: this happened at work. It was not your fault. You did not make it happen. It has just happened that it happened at work, and the state dictates anything that happens at work becomes workers' compensation. But it's for you to describe to your physician. So at all times, be cognizant of the fact that you as the patient have all the rights, but unless you tell those rights either to the judge or to the physician who's doing the independent medical evaluation, you're not doing yourself justice. Many times in practice you get asked the question, "Doctor, do I have arthritis?" Or you're being told, "Doctor, I have arthritis." Or sometimes, "I was told that I have arthritis." Arthritis is just simply inflammation of a joint. And inflammation of a joint, all of us can recognize. Anything to do with pain can cause inflammation. Anything that has to do with swelling. It can be acute, whether it's recent onset. It can be chronic, if it's been going on for years. A lot of times, sometimes it doesn't matter what the arthritic process is. The treatment sometimes is the same. But recurrence of it, the treatment has to be for the underlying condition. So we can consider some of the common forms of arthritis that we see, but primarily the 2 most common that we tend to see is osteoarthritis and rheumatoid arthritis. Much more common in our population is the osteoarthritis. And osteoarthritis are the changes, the degenerative changes that tend to be undergone by the joint itself. When we think of a joint, an average joint is the bone itself. Let's say, for instance, the bone plus the cartilage around the bone and the articular surface of the cartilage as it rubs one bone against the next. In order to give it the dexterity of motion and movement that we sometimes have, it's that the rounded edges of the bone must have another articular surface, not a bony surface, but a smooth cartilaginous articular surface in order for it to have the fluidity of motion. And then around that joint must be something that keeps the fluid within that joint. And then also something that tends to strengthen that joint. So we have ligaments and tendons. Every joint is basically of a similar nature. It depends on the strength of that joint. For instance, the hip joint will have a lot more strength in it because it carries so much more weight. The knee joint itself will have a similar amount of ligaments. But because of the position of it, we don't want to be sliding forwards or sliding backwards, so it's held in place by struts. We don't want it to wobble on itself, so it's held in place by ligaments itself. But what are the arthritic changes? It's when the bony changes that tend to undergo degenerative changes in osteoarthritis. Either overuse of the hands itself, in a case like this hand, shows osteoarthritic changes with the articular surface of the cartilage itself being eroded. But it's not hot and angry looking, as you would find in rheumatoid arthritis, especially when it's flared up. You would find that the deposition of the pannus, which is the inflammatory process that occurs, make the joint looks very painful, hot and angry looking. The similar takes place in gouty arthritis, that takes place when we have gout and involving the metacarpal phalangeal joint classically of the big toe, and tends to be extremely painful. But when you look at the joint itself, you look at the skin itself, the skin is inflamed, it's tender, it's tense, and it's angry looking, as opposed to the osteoarthritic changes that are much more common. The osteoarthritis primarily affecting the cartilage and tissues that cushions the ends of the bones with the joints itself. It may affect the joints itself, but usually tend to be asymmetric as opposed to rheumatoid arthritis. Rheumatoid arthritis tend to be symmetric in the joints of the hands, tend to occur in the distal and the proximal interphalangeal joints of the fingers itself, and that tends to affect the bigger joints much less, but can still occur within the bigger joints. Now, this seems to be the distribution in the hand itself of rheumatoid arthritis, which cause the redness, the warmth, and the swelling of the joints, and usually affect the same joint on both sides of the body. But it's also in rheumatoid arthritis, it's also associated with other general symptoms of feeling unwell, the malaise, the fatigue. But in addition to that, because it's also a collagen vascular disease, it tends to be associated with skin manifestation and other organ systems being involved, whether it be both the cerebral, the lungs, and the rest of the joints. It tends to be that person with advanced rheumatoid arthritis tend to be a little bit more introspective, a little bit more depressed, a little bit more generalized symptoms of being unwell, as opposed to the osteoarthritic person whose similar symptoms tend to be localized to whether it be the hands from the overuse, the knees or the hips, but then tend to have no underlying factors that seem to be affecting them, and they have a better prognosis, especially if treated. They tend to be the older individuals as well. Among the other causes of arthritic changes that we find in patients complaining with arthritis are things like other collagen vascular diseases, things like systemic lupus erythematosus, in which you prevent with asymmetric joint aches and pains. But the most sinister factor that you tend to see is a chronic renal failure that tends to develop after prolonged diagnosis of SLE. We also find in terms of juvenile rheumatoid arthritis that young person who tends to have the painful joints and positive rheumatoid factor. Not as common a situation, but much more common for a younger person to be presenting with these kind of symptoms. Tendinitis and bursitis and fibromyalgia are other signs and symptoms of diseases. A bursitis is just an inflammation of the bursa of that particular joint, and the bursa is just that cushion that occurs around the joint itself, not in the articular surface of the joint, that tends to be associated with inflammation. Subacromial bursitis can cause pain in the shoulder joint, but it's not within the shoulder joint. It's an acromion process of the shoulder joint, which is external to the shoulder joint. So other factors that can cause arthritic changes, the common ones for us are osteoarthritis, less common things to do with rheumatoid arthritis, and then the sequelae of things of other collagen vascular diseases like systemic lupus, fibromyalgia, and other causes of tendinitis and bursitis. As we continue our discussion on how important it is for us to know as much as we can about physical structure, because for us it's the only one we'll ever have. And if you find out as much about it, it will help us, one, to understand our feelings when the day comes, but in the event of an injury, it will also help us to be able to much more vocal and much more deliberate in terms of describing what we have. It's important. I find a lot of patients find comfort level in terms of me telling them what's going on with them. But sometimes in the course of the event of the day, you're not able to tell them or do justice to their time. And sometimes at the end of the day, you feel as if you did not do justice to them. But here it helps is if you're able to educate them as to what your anatomy is in terms of particular parts of the body that are affected. At the time there's an injury, God forbid there's no injury, then your education would have been worth it, because then you can educate other members of your family who have had similar problems. It's never an education about your own body that's ever going to be lost that you cannot share with another. That's for me the reason why medicine for me has been the greatest single most important investment I've ever going to be making with my time. I never knew at the time when I practiced medicine that it was anything to do with an income to be made. I just felt it was the most important thing that I need to find out. What is this little structure that I carry around, running around all the time? What does it do? How does it work? What makes it function? What makes it doesn't want to function? And if that's the knowledge you impart to patients, relatives, and friends, it behoves you at all points in time that you actually be able to carry as much information, whether you be a patient, a relative of a patient, a physician assistant, a physical therapist, whatever profession, the man who sells the meat, the man who's a carpenter. For instance, on Saturday last, I saw a patient with a nail puncture wound all the way into his hand itself, an entire 3-inch nail, and walked into my office and showed it to me. Obviously, he was not very distraught about it. He was distraught about it, but the employee was much more distraught. Lo and behold, they did not realize the sequel of that injury was going to become forming a palmar space abscess, which resulted in him having to be hospitalized to 2 to 3 weeks because of the infective process. Had he been seen the day before, or maybe 2 days before, when the incident occurred, that would not have been necessary. The two most common joints that I see in practice that tends to make patients come to the physician are those involved in the hip joints and the knee joints. And the hip joint per se, when we actually break it down, you break it down, and there's a previous discussion, into the joint itself. With the head of the femur, as it articulates with the acetabulum in the ischial process, that joint itself is just made up of the bone itself with the cartilage around it and the ligaments around it. Much more commonly, then we clothe it and we clothe it with a lot of additional muscle to give it support, and then the ligaments. Can we damage the joint itself and damage the blood supply and damage the neurologic supply? Yes, it's quite common. And it's important for the physician to know this, but it's also important for the patient to know it. As I saw a patient yesterday who basically had compression of the anterior tibialis nerve and caused a sensation, numbness over this area. He was very vocal in terms of describing it. I did not expect him to understand that this was the nature of his symptoms. But it's so important once we can say to a doctor, I feel numbness over this particular part, and don't feel foolish about it. Because it's not in the figment of your imagination that you're feeling this. It's as a result of what you are feeling. But the more you understand, and you don't need to make diagnosis, but the more you understand what's going on with yourself, you can also be able to say, doctor, I'm having pain in the knee. But you know what? I used to have pain before, but I never had instability to do with it. I never had the sensation that I feel as if I'm going to lose my balance. You know what? In addition to that, when I go down the subway stairs, I feel as if my leg is going to be given away. Here again, there's two very common diagnoses to make here. He's got evidence, or he or she has got evidence here, of the collateral ligaments being either loose or partially torn or completely torn. That's an indication for an MRI. You also have evidence here that the person going down the staircase is having evidence as if the lower part of the leg is moving ahead of them, and they feel as if they're going to be slipping at any point in time. You know there, the only thing that keeps the tibia, which is this portion of it, from sliding forward from the upper portion of it, is the anterior cruciate ligament. That can either be torn, bruised, or completely ruptured. And those are the things you're faced with when you as a patient come to a physician with at least the confidence of saying, doctor, this is what I feel. And at no point in time that I know it will a doctor dismiss it to you publicly or even in his mind, but actually be more prudent about giving you a proper diagnosis. And a lot of times for our own patients with our own communities is because we do not have the confidence that goes with us. I do not think you need to learn medical jargon. As I found that I don't need to learn too much legal jargon. I just need to be able to describe as lucidly as I possibly can the events that took place. It is up to you as the professional to discard or to accept whichever ones. Here again, I don't want to sound as if I'm an expert on giving legal advice. But the same thing, I don't want as a patient to be an expert in giving medical advice. But you are an expert on yourself in terms of discussing your symptoms. And at all times when you go to your physician, you are your expert in terms of describing your symptoms. You may not be the expert in terms of diagnosis or in terms of prognosis. Diagnosis meaning what you have as your symptoms of the disease process, and prognosis, what is the sequelae, if left untreated, of this particular illness. Hence the reason for you to have the physician. But in terms of describing what you feel and how it affects you, you are the expert in that, because you are the only one who's going through the process and no one else knows about it. So in trying to educate our own community in terms of the things that I have found over the last 20 years in practice in Richmond Hill, is that basically our people tend to be less assertive when it comes to describing those illnesses that they are suffering from. And sometimes feel, especially when faced with maybe a physician who are not of the same background as they're from, tend to be a little much more timid in terms of describing their symptoms. But at the end of the day, you will still be considered the expert of your own disease processes. Us as physicians, us as healthcare personnel, are there to guide you through the process in terms of coming up with the right diagnosis. But in terms of describing what you feel, how it affects you, how it has affected you in the past, how the progression of your treatment, whether it be in a workers' compensation case, a no-fault case, a major medical case, in terms of both systemic illnesses involving joints itself, chest pains, difficulty breathing, headaches, dizziness, etc. It is you as the patient who probably has the most information to give to that healthcare personnel.